My name's Dr. Stephen Lane. I am here to moderate this panel on privacy and consent. Very glad you're all still here in the room. It's been a great day so far, and we hope to continue in that vein. We've got a marvelous panel here with us today to dig into this important topic that really does dovetail and integrate with the other issues that we've been addressing during the entirety of this conference. The description of this panel that they published, I think, is very, very helpful. As the value of health data has grown, so too has the tension between patient privacy and the need to enable health information sharing. The panel, we hope to discuss how we can better align the beneficial outcomes of data sharing with the appropriate exchange that meets patients' privacy expectations. So it's a tall order. It's something that some of us have been working on for a long time. We've got a marvelous panel here with us today. We've got Adam Davis from Sutter Health, who's a pediatrician, clinical informaticist, who's going to talk to us about sort of the real-world impact of these issues on the ground in clinical care. We've got Mel Soliz, who's an attorney who works with a lot of different organizations, is here specifically representing Velatura, but has great experience working with providers, HIEs, and others in navigating these complex waters. We've got Matt Spielman from Edifecs, who I think is sponsoring this.
That's right.
Thank you for that. Who plays a critical role in data exchange and also needs to manage privacy and consent issues, and Nichole Sweeney, whom many of you know, also an attorney working at CRISP Shared Services, knows in detail what's going on in Maryland, one of the bellwether states in this whole domain. So really a great panel that we're gonna dig into. I, again, Stephen Lane, I'm a practicing physician, and I serve as Chief Medical Officer at Health Gorilla, which is one of the QHINs, as you probably all well know, working on TEFCA. And we also work in California as one of the Qualified Health Information Organizations, or QHIOs. California has its own data exchange framework that it's been working on, which is oftentimes complementary to TEFCA, but also has its own privacy concerns. California is another one of the states that's been fairly proactive in developing state-level legislation to support the privacy and assure appropriate exchange of highly sensitive data. I've also had the opportunity this past year with Devin McGraw, who's down here in front, to co-lead a privacy and consent work group at Sequoia project. This has been a very well-attended, very participatory group of Sequoia members and some outside subject matter experts, some of whom are also here with us today. Our work group had a number of meetings during the course of the year. We heard many presentations from outside experts in the field, really doing a full landscape assessment. There is a QR code on a poster out in the hallway that you can use to get to all of those presentations if you want to dig deep into this. The work group is putting the finishing touches on a white paper that we are going to probably publish finally within the next few weeks to get out. And that work group is also going to initiate a new Sequoia project community of practice that will be focusing on privacy and consent issues during the year ahead. Devin and I are going to help kick that off going forward, and we're going to bring additional folks in to participate so we can come back and talk about that more at the end. So with no further ado, let me jump in and just invite each of the panelists to introduce themselves, talk about your organization, talk about your perspective on privacy and consent, both where it is today in your world and where it needs to go next. Because that's going to be our focus throughout this talk, is where do we need to go next? So Adam, you want to start?
Yeah, as Stephen mentioned, I'm a pediatrician in San Francisco. I work for Sutter Health. I'm also the CMO of Serving Communities HIO, so have some regional HIO experience. And I think there's two big, sort of movements in privacy and consent that are happening One is sort of the increasing exchange has led to changing of patients' expectations. And the majority of complaints that we get is, why can't you see my data? But the loudest complaints we get are, why can you see my data? And so figuring out how to deal with both those complaints, and we are really proud of the work we have, that we are able to get the data most of the time in front of the doctors who's providing care. That's the work that the giants have done over the last 15 years. But we remained concerned and newly concerned about, why can they see their data? And part of that is in reaction to, the changing legal field of the Dobbs decision, and how different types of medical services are interpreted by different states, and what risk that puts for our patients and our providers. Maryland and California have both passed laws, and I think New York is considering one, and I think other states will follow, that sort of change what you're allowed to share and add a geographic sort of aspect to data sharing, which we did not previously have. It also adds a segmentation. We've previously had some laws around substance abuse, but we're seeing laws around reproductive health. We will see laws around gender-affirming care. And that segmentation is something that the industry hasn't mastered yet. It's hard. And so I think the two things that I think about is, how can we do privacy and consent more granularly, with segmentation and geography coming into mind, what tools are available to do that, and how can we do that in a way that's manageable for the provider, for the patient, that's transparent for them. And I think it's a really tough nut to crack, and I certainly don't have all the answers, but I'm excited about the conversation.
I am too. My name is Soliz. I'm a data interoperability attorney based out of Phoenix, but I'm here today as outside counsel for Velatura HAE Corporation. And the community health information exchanges, also known sometimes as health data utilities, have had long experience dealing with these privacy and consent issues, dealing with everything from opting out of the manner of exchange for health information when patients don't want their information exchanged through third-party intermediaries like health information exchange, to operationalizing consents to share substance use disorder data that's protected by 42 CFR Part 2, and adding to the tools that are available for doing data segmentation. There's a lot of talk in the community, right, about using sensitive code softwares where you're using the diagnosis codes and the CPT codes to help do sensitivity tagging. But there's also the ability to do data segmentation at the facility level. Where is the originating source of that data? Because as we'll talk about on this panel, a lot of the ways that the laws are written aren't written to data segmentation solutions. They're not written to the tech. They're written to who created the data. So there's lots of lessons that can be learned from what the community HIEs have been doing for decades that can translate into our national frameworks, where there's opportunities to create kind of those minimum standards that we need to have in place if we want to maybe operationalize nationwide substance use disorder sharing in alignment with 42 CFR Part 2. So very timely topic, especially with the focus today on frameworks like TEFCA and care equality.
I'm Matt Spielman. I'm a Senior Director of Product Management for Fire Strategy and Roadmap at Edifecs. I've been doing healthcare IT for about 25 years. Started really in the trenches, standing up clinical systems, figuring out how to integrate back in the days before we had the kind of one-stop shop for EHRs, where there was a lot of integration required to get systems to talk to each other. For the last 14 years, I've been working in a product management role, building out software for large-scale health data aggregation and exchange. I would be willing to bet money that just about everybody in here either uses software and technology that I helped to build or talks to an organization that does. Similarly, in my role at Edifecs right now, taking much more of a focus on the needs of interoperability on the payer side of the market. There is a lot of pressure as a result of recent CMS mandates to drive interoperability between payers and providers and push payers to maintain a much more robust and longitudinal health record for their members to facilitate both continuous coverage, so coverage when there are two plans both providing coverage for the same member, as well as also transition of coverage when you move from one plan to another, as well as electronic prior authorization. And then as we also look at the needs for health plans to acquire clinical data to support value-based care use cases where there are shared risk contracts with providers, helping with stuff like risk adjustment, trying to cut down on provider abrasion, identifying gaps in care too, as we talked about in some of the conversations yesterday, where we were talking about what is treatment. You know, how do we identify gaps in care and deliver that to providers who need that support when it's not considered treatment, and we're essentially locked out currently from all of the national networks right now. So there's the work happening with health plans right now is really trying to figure out, if we don't have access to the national scale networks, how do we facilitate national scale point-to-point connectivity between all of these plans so that we can have that level of exchange? And there are the exact same issues of trust and consent that we have to deal with on that side as well. So there's really this convergence that's happening between the two sides of the market that I think are going to really start pulling all of these use cases together.
And hi everyone, I'm Nichole Sweeney. I'm the General Counsel and Chief Privacy Officer for CRISP Shared Services, which provides technology and resources to HIEs throughout the country. And then I serve the same role for the HIE in Maryland and the HIE in DC. I think I'm supposed to talk about other things that I'm on. So I'm also on the Care Quality Steering Committee, and I'm, excuse me, one of the representatives for the TEFCA Transitional Council representative for eHealth Exchange. So what I want to talk about today and what I get really excited about are tipping points. So when you think about how industries change or how we change as a culture or how we progress as a culture, it's not a straight line, right? You sort of see this. There are some things that happen and it looks like straight line progress, and then something will take a step back, and then all of a sudden you go from 25% to 100% overnight. I saw this yesterday when we were doing karaoke with the Care Quality folks, right? You know, there's a name board that you put your name up on, and first it's like one person, and then it's another, and you're all kind of like, hey, you know, you should sing karaoke. And it's not just linear, right? It's not like every minute someone goes up and puts something on. Of the first two people, it takes a while for them to go on the board. Then there's like a couple more people, and then all of a sudden, everybody that's there is like, yes! And you've got the board full for the rest of the night, and it happens just like that. And if you've been paying attention, and sometimes I don't at conferences, but if you've been paying attention for the last couple of days, we're at a tipping point. If we're not there, we are very, very close. Very, very, very close for privacy and consent and how the system is built. We're seeing it with arguments about what is treatment. We're seeing it with arguments about who should be on the network and who shouldn't be on the network. We're seeing it with lack of patient trust and DOBS. And my question for all of you is, do you want to be ahead of the tipping point, or do you want to be scrambling? Because if you are not ahead of the tipping point, which I think is going to be here by next year, then you are going to be catching up with 50 states and 6 jurisdictions. And it's not going to be fun. And let me tell you, having been a part of it, what legislatures in different states make as solutions is not ideal for those of us in the room, and often not the most ideal situation for patients, especially patients who are getting care across state lines. So if we do not come up with a solution, a technological solution in this room in the next couple of months, we're going to be coming up with 56 different technological solutions, and it's not going to be good for any of us. The tipping point is here. Do you want to be falling down it, or do you want to be ahead of it?
Great introductions. Thank you all. So a couple of you have mentioned DOBS, the DOBS decision, which did away with the protections, nationwide protections for reproductive health services, specifically abortion care. And I think that, you know, we're all well aware that that really was a shift of the ground in our industry. that for decades, we've been working to digitize healthcare, to move the data, to lay the pipes, to really open up information exchange for the betterment of care and for patients. And that was based on a certain set of assumptions about privacy. And with the Dobbs decision, those assumptions changed. And suddenly, we were looking at what were really unintended consequences of the great work that we've been doing together over all these years. And suddenly, there were risks to information sharing, risks to individuals, risks to providers, legal risks, sometimes, real physical risks that occurred. And I think we've all been kind of scrambling since then. I mean, I remember being in meetings within the first couple of weeks, after that decision came down with some of you, and going, what are we going to do? And we've really been in that kind of what are we going to do mode for a long time. And I think your point's really well taken, Nichole, that it's time. Especially I think now with a change in administration, we're going to see a different set of foci coming at us from federal legislators, from state legislators, and it is going to happen this year. So I mean, I think it's incredible how much work has been done, but none of it has really been to scale. We don't see standardized solutions that are shovel-ready that people can just put right into practice. So I think our challenge is to figure out what can we as a community agree on is the next thing to do so that we all can move forward together to improve privacy in the new current environment as that environment itself is defining itself. We don't even know exactly what that's going to look like. So, I think I just want to kind of paint the picture, right? We've had for years that we went from kind of opt-in to exchange to, we assume we're going to exchange unless you opt out. And then there was a certain number of laws that required consent. 42 CFR Part 2 comes to mind as the one that everyone has had to deal with. But then in various states, there were little pockets of consent requirements that bubbled up. And there have been implementations of technological solutions that have been kind of one-off for the most part, that have allowed people to say, well, we feel like we're complying with Part 2 because we've got this in place. A lot of that compliance was managed through opting out, through just saying, well, we're just not going to share Part 2 data. That was, so that notion of opt-in, opt-out, just a blanket consent one way or the other is really what we have experience with. And it's fairly limited, and again, it's been focused on Part 2. I think SDOH data and social care that occurs in the community, it's sort of outside of HIPAA, it's outside of the healthcare realm directly, and therefore we're just not going to go there. A couple of you represent, HIE or HIOs. Actually, I think all of us do at some level. And there again, those often are organizations that don't hold the data, but they transmit the data. And, so you have different options, when you're talking about opt-in, opt-out, do you even receive the data? If you do you hold on to it? Do you pass it on, et cetera? So there's a lot of complexity just in that whole opt-in, opt-out model. And now what we're hoping to go to, and I guess I want to ask you if you share my hope that we are going to a more granular way of managing consent, where individuals can say this type of data in this situation does or does not need to be shared, or should not be shared. Because it seems like that's where the laws are going, certainly Maryland, California, getting very specific about don't share this data. And we have seen the industry develop the tools that we need. There are incredible standards, and the authors of those standards, I hope, are in the room, because I'm going to call on you later, Mohammed. But now the question is, how and when are we going to actually implement? Or do we have the wherewithal to implement these new tools? I'll point out, from my high-tech experience that then ONC proposed specifying sub-pieces of the established standards for implementation, for a requirement for certified health IT, and then that didn't happen. And maybe Mark Nee can talk to us more about that later. But so even in the now waning administration, there was not the wherewithal to make this an actual requirement. There was a sense that the industry wasn't ready yet, but yet the industry needs this. What kind of ready or not, here we come. So I'm really interested in each of your perspective. First, do you see the goal as moving towards granular consent? And if you do, where do you think we are now, and what really would be the next thing to do to move us in that direction? And go ahead.
So, I think a few things that I think of when you speak of it. One, yes, I think we all have this dream of this granular consent world where patients have control of their data and they move it to where they want it to go. And it's a patient-centric view. But there's also a balanced view that I have there, and I think a lot of Anna's presentations yesterday and about how much time she spends managing her own care. And I think about how easily complex that could easily, if we do the design poorly, how hard it could become to manage the segmented consent model. So you could imagine that you have 5 or 6 different categories of types of treatment that you have to choose whether to consent to. Then you have rows of different types of doctors that you see from different institutions. And honestly, you may not know which institution your doctor's at. So when patients come see me in my private practice, I'm on UCSF EHR. It's not really advertised anywhere. I guess the My Chart, they know that it might be UCSF, but we're not UCSF employees, we're not UCSF doctors. We use their Community Connect model. And that's true for a lot of people where they know their doctor or their doctor's group, but they don't know the overarching health system that it's a part of. And then within that group, so say a patient comes and sees me, they need to decide which pieces of their data they want to share from me. But then they also need to do that for every other doctor they see, and this becomes a third 3D dimensional grid that they have to maintain and keep accurate in order to protect their data. And I'm worried about the ability to do that in a timely fashion and in a fashion that respects everybody's understanding and ability to get through all that legalese we're of course going to put into the system. So yes, I want that goal, and I also want us to think about UX and where that's housed and how it's shared between institutions so that the consent that they give at my office can be similar to the consent that they are able to give at another office. I will say that right now in California, we don't have time to wait for this because we have to comply with our bill, which is AB 352. And the decision that's being made is really the rolling back of the opt-in for patients who are flagged for having reproductive care by discrete measures of a value set, a grouper, right? And that's what most people are heading towards. There's other tools available, but man, what a bummer. What an intense bummer for the vast majority of our patients who are trying to move within our state because we can't differentiate out-of-state and in-state actors, right? Because we really haven't built the infrastructure for that. When Stanford, I could send data there, but Stanford has offices outside of California. And so does basically every organization in California. And if we want to get really technical, most of them store their data outside of California, even if they don't have offices outside of California. So it's a really tough question to answer. And I struggle with the easy answer of what we could do in the next year. But I know at the very least, I want to be able to start stacking functionality. So what I mean by that is if you're going to be able to segment, I want to be able to at least turn on consent for that piece that's segmentation. So right now, for example, for substance abuse, it's just not sent. And sometimes you want to be able to send that. Or if a patient's moving from California to Massachusetts, they might feel very comfortable having their abortion services travel to Boston. But we can't do that. We either segment it all or we segment none of it. And so right now I want just the tools that are available to be additive, not in separate silos. But I want to deeply discuss the user interface of this.
Can I add something?
Sure.
So I think I've been really thinking about this a lot in the last couple of weeks, and that we don't actually need consent if we move to the goal of patient-facilitated data exchange. And I've been thinking about that as airdrop for patients, right? And there are a lot of equity issues involved in that, and how would you do that with different devices and various things like that. But I've been thinking about, and this probably shouldn't be on a panel where I'm like half forming things while I'm talking about them, but here we are. Do we even need it? Is the ultimate goal granular consent, or is it 100% or close to 100% patient-facilitated exchange of their data, and the next is granular consent, but the very later goal, maybe not even very later, is patient-facilitated data exchange via something like a airdrop for patients or something like that. So I've also been thinking about that, just to throw that out there to the panel.
I think the answer is both, and you have to have both, because the thing is, going back to the concept of a blanket consent or a global consent, consumers, once they get the airdrop, might want to send some of the data, but not all of the data. So even on the consumer side, they need the segmentation tools on their end. So I think we have to develop it. And where the additional complexity comes in is it's really not just the data segmentation on what a patient thinks is their sensitive data or their substance use disorder data. We have to write the technology to the laws, and the laws are different in every single jurisdiction. And unfortunately, there does not seem to be a big appetite for a single privacy law to rule them all. We don't have federal preemption, and if we're going to continue to live in an environment where we have different laws in different states with geographical boundaries and people working across the way, and then at the same time, because the patients don't know what the laws are. What the law says is substance use disorder data probably isn't what a patient thinks is substance use disorder data.
Yeah.
So we need to develop the tech. And I think, CMS is already behind the consumer-mediated model. That's what the CMS interoperability mandates are all about. And we need to have a lot of tools in the toolbox. It's data segmentation. It's also being able to restrict the sharing of data based off of who created it, and not just at the facility level, but also on an individual provider level. And then on the flip side, who it goes to. And this is where I love to hear more about what's in the work for tech.
Yeah. So this is I'm going to tread very, very delicately on this topic. Only because I don't want to offend, because I know that there are people who are very passionate about the topic. So I have developed a patient portal application from scratch, and I have then also worked with the CMS 9115 rule, which mandated member-mediated data exchange, so being able to both enable members to access the data that their health plan has, as well as facilitate a peer-to-peer data exchange in a mediated model. And from my perspective, again, I'm trying to be very diplomatic here, there is a very small subset of patients who are actively engaged in the use of these kinds of tools. They're either very tech savvy, or they are chronically ill with multiple conditions, or caring for somebody who has that. So for example, I could absolutely, like for example, my father passed away recently. At the end of his life, he was dealing with a number of very complicated conditions as well as dementia, and wasn't really able to answer questions. So being able to have his health record on my phone was very valuable when I was going with him from specialist to specialist. But for me, as a relatively healthy person, if I downloaded my record to my phone, how current is that? Am I updating it constantly? What if I'm incapacitated? There still needs to be that system-to-system communication, and I think still fundamentally that is going to be the backbone of exchange. And where we get into the challenge, when we then start talking about the differences across states, different policies, different other things, is that we can sit down and we can have a conversation about what is treatment. And all of us can say, I know it when I see it. That's not how computers work. Mm-hmm. Computers work off structured data, code. When we write products, right, we need to say, okay, you want us to block reproductive health data, tell me what the reproductive health codes are. Identify for me which kinds of facilities provide reproductive health services so that we know to block them. It's tricky for a number of reasons. One, because these value sets change all the time. But then additionally, it's when we're also we talk about how do we move records back and forth when we want to restrict this data? Who is responsible for restricting the data? It has to be kind of a zero trust model, right? The organization sending the data has to enforce the policy, has to enforce the patient's preferences. How do you transmit patient preferences in a standardized way from one system to another is a very complicated thing, particularly if you're trying to protect privacy, because you can actually violate privacy by expressing a consent policy that is too granular. So for example, if I say, I don't want my record from reproductive health facility XYZ on the dates from September 30th to October 1st shared with anybody, that's as good as saying I received services from that organization at that time. So we need to have a very uniform and common agreement on what value sets, how we're coding things, how we're expressing these policies, so that we can provide enough granularity so that, first of all, we don't have the bad user experience of the patient saying, oh, well, I got to select this code and this code and this code and these providers, but also so that it's reasonably computable, so that as software developers, we have the ability to actually do other things besides just writing insanely detailed product to deal with this one thing, because ultimately our products still have to deliver value on top of all of that, and then having it be transmittable in a way where a consent policy isn't megabytes of data in and of itself.
And in the ideal world, that could live in a state level HIE.
Yes.
But not every state has one.
Yes.
And I guess I'm sort of Boston-centric because that's my hometown, but I live in California and do all my work in California, and we don't. And it's hard to imagine the environment for which a shared consent platform would live in California in a way that could be shared throughout California in today's environment. Now that could change in a year or two, but it's a real challenge, and I don't think there's a future where the feds are going to wrap up this issue for us again. I think we really are looking at, perhaps not a 56 solution, but a solution in the dozens, right? And so, in California, Maryland approached the law very differently. Maryland wrote out discreetly what codes they wanted, and California just said this type of care. And for us, that's hard because that also includes notes, which is, we don't have the language processing tools to deal with yet. And so, I think there's real challenges, obviously, but those are some things that I think about.
And you can have 56 different solutions if you have one core governance technology platform in each of those 56 states and territories that is the background of those. So computable governance solutions, that's where we're moving to in Maryland. Along with the reproductive codes, Maryland also has a regulation that came out, proposed regulation that came out a few weeks ago and hopefully will be finalized in Q1, that requires every entity that it's exchanging data within the state of Maryland to connect to a consent management application. And it's going to start with the opt-in and the opt-out, but it's going to start having those granular computable buckets that everyone connects into.
And I'd like to key off that again, also sort of as an architect, as a technology architect, and sort of thinking about this landscape of interoperability that we're in right now, where it's not just FHIR and it's not just IHE transactions and CDA documents, it's HL7 V2, it's X12, it's proprietary applications that are serving stuff up through web interfaces. The health plans that we work with as part of 57F have to make through the patient access API, the provider access API, not just the data they receive via FHIR, but even the data they get via fax machine. And if somebody's on their web portal typing stuff in. And so I think when we're talking about I think you are right that this is a problem that, given the current climate, I think can only really be solved effectively at the state level. I think it's going to be incredibly hard to solve it at the national level because of the impedance mismatch between sort of there's even difference of what constitutes opt-in or opt-out in some cases. Does it include opt-out exclusively or opt-out except for emergency, break the glass, like there's all these sorts of things. The key thing though is we need a central service that can express a computable consent policy, but then for the organizations, the software, the platforms that are participating in the exchange and have committed to respect those, they need to implement their own policy enforcement. So I make this distinction very clearly oftentimes. There's consent policy management and consent policy enforcement. As the organizations that are responsible for sharing or not sharing data, they are responsible for the policy enforcement. And that's an important distinction because I don't want to think about policy enforcement just in the context of what I send out as fire. I want to think about it in terms of what do I allow people to query my population health database for, or what do I allow them for other things. So we've got to sort of, again, think about it in those two very distinct terms.
So I want to transition us to audience participation because this is a group of amazing experts and we could stand up here all day and continue this discussion. But we also have a number of experts in the audience, as I suggested earlier, and I want to give some other people a chance to talk. So I don't know if we have mic runners or people just have loud voices that they can jump in, but I mentioned earlier Devin McGraw, who's sitting down here in front, who helped to lead the Sequoia work over this past year and is going to help us to kick off our community of practice going forward. As you've all heard, Devin is a past master in these topics. And Devin, I just wanted to give you a chance to since you're not sitting up here, to say, where do you think this needs to go next?
We're not getting some really odd stuff out of a group of folks who don't necessarily, who feel the pressure and they have a desire to make a change, but they don't sort of fully understand how to get that done. And you get a bunch of legislative language that you're stuck with, and the poor agencies, which there are many of you out here, trying to figure out how the heck to implement it, as well as the stakeholders who are affected by it. So it's just in terms of community of practice, maybe the first thing is what should this ideally look like from a policy standpoint? How can we coalesce around something that we can share as a better solution while we're continuing the improvements on the feasibility of the tech around segmentation? Because the advocacy groups, that's what they want. They got some segmentation out of 2 states. They want more of it. They don't want less than what they may have already gotten, and it's not an easy thing to implement.
Well, let me follow up on that, Devin, just because, as a couple of people have mentioned, the segmentation is based on having value sets. What are the specific codes that represent? No, it's absolutely more than that. It's necessary but not sufficient.
Exactly.
Yeah, that's my point. And since nobody mentioned it, we do have value sets. A lot of work has been done, originally coming up through folks at the National Association of Community Health Centers, but then with much broader participation. Value sets have been delivered by the state, in the case of Maryland, by this collaborative group in the case of California, and there is a mechanism now, a nationwide mechanism for value sets, and just last week, a commitment was made to bring those value sets into HL7 for ongoing care and maintenance. And I want to call on Hans Buitendijk, who can speak both from the HL7 and from the EHRA perspective. Hans was also very involved in our work group this year and will participate in the community of practice going forward.
Yeah, just to follow up on with the microphone. So to follow up on that a little bit, one of the key points that was raised in the discussions on the panel is that one of the pieces is what sensitive data. And yes, there are places where that is clearly defined, and there are places where it's being indicated. Figure it out yourself, and anything in between we probably can expect. So HL7 has agreed effectively that that's where we can find a place to coalesce those sensitive data definitions and flags that are needed to manage this, so there can be consistency around that. Relationships with the jurisdictions, relationships with other parts in how does it relate to standards where they're known, V2, CDA, 5, but they can also be used with non-standards, as was indicated. It needs to be used everywhere. So we are starting from that perspective to look at, in HL7, not just starting to look at it, we are actually to the point to define the specific project, the work group, everything, so that we can maintain that and have that ability to have a single point where people can begin to look at it and say, okay, if I'm doing it for one state, another jurisdiction, what do I use, and what else do I need to use that in HL standards or otherwise. So that's at the starting kickoff, and hope to have that going early next year, so with efforts there. So stay tuned. Will be announced widely as we know time, place, and participation listservs and all those kind of stuff. And pick up on the great work that has happened to date. So don't replace it. It is continuing the work and have a home for that.
So I think a good point, Hans, is not only do we need to have value sets regarding the data itself, but we also need to have shared value sets for the sensitivity tags and a shared set of technology tools that allow us to move forward. And that work, again, has been done. Mohammed, are you in the room? I can't see through the lights. Way in the back. Somebody chased Mohammed down with a mic in the back row.
He was here yesterday.
Yeah. But I think it's important to realize, it was set up here by a couple of people. 5 years ago, we didn't have the technology. Now we do. We have the standards. We have it for CDA documents. We have it for fire. And we have people committed to moving those standards forward. So maybe, Mohammed, can you just say very briefly, where that work stands?
So we did have the fire DS4PIG that I think it's been 2 years since it was published, and we just passed the PSS at the Security Work Group this week to support an update to that. And part of the work that's been there's an inventory of things that need to be done to update that standard, one of which is basically to overhaul the sensitivity tags and have an update on that, and also provide guidance in the US realm what sensitivity tag should be used for what category of data based on the jurisdictional regulations and the laws that for each state. So DS4P is the data segmentation for privacy. So we do have data segmentation guidance for V2 and CDA. These are kind of older standards. They primarily deal with how to basically incorporate that into the data format. But the Fire DS4P, which is the latest version, went much further than that. It has extensions to record metadata for data tagging. There's going to be further implementation guidance on how to implement a data labeling service. And there's also the references to the value sets, as Dr. Lane mentioned, for different sensitivity categories.
So tremendous progress has been made. We're at this tipping point. It's time to really roll up our sleeves and implement. now. Not just unique solutions at a regional level, but really tools that we can all implement together. Hence, Sequoia Project in its role as convener, is sponsoring a new community of practice that is going to go forward beginning with the new year. Michael, are you making trouble?
Stephen, the other thing that I would ask care quality and implementers and Sequoia Project to think about is whether we need to, the requesting institution needs to send more data in the request. We've talked about before about purpose of use, but the other delimiter here is physical location of the request. So right now we get the institution that's making the request, not the actual where did this request come from. And I think some of us would interpret it that if, it is on the receiving institution's responsibility to then be the protector of that leaving the state if they request it to a site within the state. And right now, that's up to each institution to decide, but right now we don't even have the ability to do that because all we get is that, an institution's making the request. And so I would love to move to a place where we had more granularity about who at the institution is making the request and from what physical address they're making.
So I think what you're getting at is exactly where we need to go, which is what precisely do we need to make that next step forward as a country, as an industry. So feel free to raise your hands. Again, we've got a mic. I know that guy. Derek, yes.
Yes. So an overall question about the approach here and sort of talking about the elephant in the room, which was briefly touched on, which is unstructured notes. So technology is great and we have a path forward on structured data and we'll hopefully figure it out. But do we need to educate people that we have to take a risk-based approach rather than an absolute-based approach on protecting the sensitive data? Because if it's going to be absolutist, we're never going to get there because unstructured data is part and parcel of everything we do in healthcare. And there's no NLP out there that can 100% guarantee that I'm going to find, gender-affirming care or behavioral health or, these different things. So just want to make sure that folks are aware of that. And is there a pushback, or do you think that the state legislatures recognize that we need to have that sort of risk-based, we're going to do the best we can, but,
I think, Derek, the point, the way I reflect back on this point, and I do it repeatedly, is perfect is the enemy of good enough to make progress. We are never going to have a perfect solution. We should simultaneously be thinking about what the ultimate goal is while we very much focus today on what is the next thing we can do.
Yeah, and I'd also like to add in that whether we're talking about structured or unstructured data, ultimately, we have to make sure that our efforts to define what the common language we use to express consent and preferences and other things are doesn't become a way for vendors to abdicate their responsibilities on the enforcement side of things. So these things need to be informative. For example, if we're tagging data, if we're marking things as being sensitive or other things, that cannot let vendors off the hook to, again, enforce those things going out on the other way, not solely based on what was the data was tagged for, but what is actually in the data, which is, I think, a really important thing that we can't miss.
We've got a question at the back here. Just stand up and shout. Oh, sorry, go ahead.
Brendan Keeler, HDD Health. A lot of the discussion right now is focused on what I would classify as moral or ethical reasons for consent and privacy. Dobbs, as we see with the comments by the American bishops and Mike Pence's think tank on HTI2, is a moral and ethical perspective. And typically moral and ethical perspectives are not universally agreed upon. Isn't a more compelling case for consent the fact that if we enable patients to see their transactions on QHINs, via QHIN, and then allow them to control it, we delegate down policing to them in a way that solves all the problems and disputes we have today. We're focused a lot on Dobbs and other similar things, but I think there's a much more practical reason to do consent very rapidly, which is we don't have to have the same what is treatment if patients can flag and say, hey, who is this law firm that's accessing my data?
Good point. Other
And
hands? Over
speaking
here.
of patient, I'm actually going to invite Anna McAllister to give the consumer view.
I have perspectives other than being a patient. But one of the things that I think is essential, is sort of an interim step, or perhaps it's not an interim step, but it's a simultaneous step that I think is critical. And Stephen, you may remember me advocating strongly for this when we were on HITAC together, looking at HDI-1, is the essential need for transparency around who is accessing the data for what and when. And until we can get transparency into exactly who is accessing the data for what and when, there are going to be two things are happening. One, for those who have concerns, they're going to be concerned that people are accessing their data that they don't want, when perhaps that may not be the case. In some cases, they may develop a greater understanding of the benefits of the data being able to be accessed by different providers in terms of making the informational burden that much less significant on patients. But I don't understand, I mean, I know that we had the great discussions about this when we were putting together our HITAC recommendations. I think until we can get real transparency around the specific types of data that are being accessed, by whom, and for what reasons, it's going to be difficult to get real clarity on and a real movement for appropriate privacy and consent, regardless of whether that's granular consent, like what we've been discussing, or whether that's a more a less granular type of consent. And I'd love to get the panel's thoughts on what might be keeping us from that level of transparency from a technical perspective. From a policy perspective, I can see some ways forward. It would take a lot of effort, but I would love to get your thoughts on that.
Well, I would too, and that's a great way to say that we are at time, and that all of you who want to continue this discussion are invited to join our community of practice. This is where we're going to go, is into this level of detail with, again, a real focus on what can we do next? What can we do now? And we actually have an agreement with the data usability work group led by Dee Dee Davis at Sequoia to work collaboratively to try to define very specific build and implementation requirements that we can bake into the next version of the data usability implementation guide, so that as to start to standardize this, because it's up to us as a public-private convening entity to do that. We're not expecting the government to tell us the way. So thank you to our panelists, amazing. Give them a round of applause. And on to the next panel.